But anyway, it's a huge topic, talking about the medications. I'll try to make it brief and concise. But anyway, like I was saying, I'm doing this for like 25 years. In 5 years, I was on faculty at UCLA, and then 15 years at USC working with residents. So anyway, I've been starting out as a young resident. ADHD was kind of one of the big ones, still is, working with kids when I was a resident, telling parents, okay, just say no and follow through. And then I had my own kid, it was humbling, and then I had my own kid, ADHD. So again, that was doubly humbling. So anyway, I can relate to all of you as well, both as a parent and working with these kids. So I just wanted to talk a little bit about ADHD itself. It's hugely prevalent. 9% of the population, they say, is the number that gets thrown around. And it's highly genetic. Gets passed down through generations. In fact, I see kids all the time. You know, I'm just talking with the kids, and the parent is just doing this, running in place. You know, and then they come to me later, and they'll go, you know, Doc, I think I got the same thing. So why is that gene persisting? It has some kind of use value. So I think we sort of say that ADHD is bad somehow, but there is reason for persisting. It does give creativity. And I think risk-taking. And I think somebody has to, at some point in time in our history, has to say, I'm going to get in that boat or eat that mushroom and go over there and do that. But when we have a misfit between our society, where you have to sit in a factory model in school, you have to learn a trade, you have to go to school, is when it becomes a problem. So does ADHD really exist? I mean, I think that it really does. I mean, there are kids that clearly are way out here on the spectrum. There's this little bubble out here, and it is a real problem, and it does exist. Because I know that people have sort of argued that back and forth, that is ADHD a social construct or not. But anyway, it does become a problem. And at what point do we intervene? What point do we medicate, I think, is a big question, because when does not medicating outweigh the risk of medication? And that can happen with little kids. I mean, age range, I've seen kids 3 years old that if you don't medicate them at that young age, I mean, it's a danger issue. Some of these kids, you can't take them out, walk across the parking lot. They'll jump out across the street, they'll climb on things, and it's a safety issue. But not only is it a safety issue, they can't participate in a preschool. And so developmental milestones for these kids to be able to participate with something larger than themselves in the milieu of a classroom. They're so spinning in their own little universe that they can't really learn, and they can't learn social skills because they're so impulsive in their interactions that kids don't want to play with them. And so they don't learn how to make friends. And then just talking about, too, the academics of falling behind. And so when you see a kid falling off their developmental milestones, you see them sort of like not making it. And that's where you see, too, a lot of these kids start developing the other problems. If you're always in trouble, you're always in the wrong place at the wrong time, you're always getting yelled at, you start seeing the oppositional defiant kind of behaviors that grow. Because it's like, if you're this little kid and, wait, I didn't do it. How did I get here? You have no idea. Because somebody brought up sequencing. They really aren't able linearly to get from there to here. They're just there in the wrong spot at the wrong time. And then they start to internalize that. That I'm dumb, that I'm a bad kid. And in fact, some of these kids, what you see, we're talking about, like the oppositional defiant kids, they get a lot of secondary gain out of their negative behavior because they don't know how to get positive attention anymore. And positive attention means you have to be able to sit in the classroom, say nice things to your friends, don't say the mean thing that pops into your mouth. But these kids can get the negative attention like that. Immediately, it's reliable. But the problem with negative attention is kind of like junk, because it gives you that immediate rush, but it doesn't build relationships that helps you to feel connected and part of the world. So that rush that you get from the negative attention wears off immediately. And so they're back doing the negative attention again. So we talked about a little bit about comorbidities, which means it's an awful word for saying that other disorders that kids develop when they have the untreated ADHD, that by intervening early, we can head off and help these kids develop more appropriately and quote unquote normally and have more successful lives. So ADHD again, what really is it? We talked about executive functioning, which I think is the hugest part. And that's the part of the brain that's up here in the frontal cortex that's telling you basically, this is important, pay attention to that. So like saliency in your environment, this is important. Not everything else that's streaming into your cortex. So it's a matter of focus, which is what's important in your environment. And somebody else brought up too, that notion of sequencing, what they call working memory. So it's both things, but it changes across the lifespan though, you notice. I think I want to talk about how it changes from little kids. Somebody brought up too, little kids, they tend to be much more hyperactive. They're bouncing off the wall. You don't really notice the executive functioning deficit. You might see it, for example, we talked about, okay, go get dressed. No, you have to break it down. Go get your shoes, come back and talk to me. Go get your towel, put it on the rack, come back and talk to me. Make your lunch or get your lunch. So you have to break it down. So you're still seeing the sequencing deficit. You're starting to see the executive functioning deficit. But what jumps out at teachers and parents is the hyperactivity. These kids are just bouncing off the walls. And so you get teachers that start complaining. And already they're being sort of like labeled and ostracized. You see the burned out teachers that want you to do something about this kid. And oftentimes the pressures to medicate come from the teachers. So that question brings up the question, are you medicating for the sake of the kid or for the sake of the teacher? Whose problem is it? You need to ask, okay? As kids get a little older, you see less of the hyperactivity, but it remains kind of an internal state of antsiness or restlessness as you start to get older. And into adulthood, you see grown-ups, they can sit still, but still be completely ADHD. Because it's changed from the hyperactivity to this inner sense of state, inner sense of antsiness and restlessness. And they have, what you see with that is the impulsivity. A lot of the grown-ups make messes of their lives because they're so impulsive. But it's still just ADHD, kind of how it transforms over the lifespan. As you get older, you don't see the hyperactivity so much. Also, another thing that you see is that the difference between boys and girls is that girls tend to be much more the inattentive type. So you can have bright girls that are sitting in the classroom and you get teacher reports, oh, they're just the sweetest kids, a joy to have in the classroom, but they're in Hawaii. They're completely checked out, daydreaming. And the kids, they're the ones, the boys are the ones that really draw the attention. And a lot of kids that are bright, I think you asked me about bright kids. The executive functioning deficits have nothing really to do with how intelligent you are. And there are a lot of brilliant kids that have ADHD, with high IQs, and so we've all worked and had experience with those kids who worked with these kids. Oh, I'm sorry, I forgot where I was going with that. But anyway, so the point being is if you're a bright kid, you can slide through elementary school, slide through middle school, and there are a lot of kids that I don't see until they're in college. And suddenly you have to be able to hold in mind what you're working on and organizing and working on it. So it's like it's your working memories, like the sort of blackboard up here. So you're writing things down on, okay, you can do that. And then you have to work it, organize it. Okay, how does this connect with this? How does that connect with that? But you talk to these kids and the experience of that, what that feels like to them, is everything is sliding off the blackboard. They can't hold it in mind. And the same kind of thing with reading. You'll start at the first sentence and they'll get down 2 or 3 paragraphs and then have no idea what they're reading and having to start over. So So these kind of presentations that you get more in college is this executive functioning deficits in the planning. So anyway, I know we're here to talk about medications, so wanted to jump right into medication. As far as we know, there's no real kind of one medication that works better than the other medication. There's nothing really been proven that one works better than the other. So it really is kind of just trial and error. You start low and go slow. And then sometimes you have to switch it out and try another one. Not everybody's going to respond to any given medication. And you might have to switch it. And there are some kids, particularly the ASCII kind of kids, they're super sensitive to medications and they can't tolerate the stimulants at all. So when you see with those, some kids who can't tolerate stimulants, you see the weepiness, the mood swings, the emotional withdrawal, almost kind of an emotion over-focus, and you see them kind of spacing out. So we started low dose, and it's not doing nothing. You go to a dose that seems to be quieting them down, but they're kind of over-focused, and you're losing some of that kind of brightness in their eyes of something you don't want to do. So the way I explain it to kids is not to sort of drug you, but to give you more control over your own brain. So it's putting it back over in their court. We're not drugging you because we're telling you and because you're a pain in the butt. We're giving you this medication to make you the boss.
Oh, that's a nice way of phrasing it.
And you want to do that early on so that they're feeling a sense of agency. Because these kids are going to be going off into college, young adulthood, and so on, and they're going to have to be taking control over their own medication. Because a lot of these kids aren't going to be growing out of it. So anyway, I just wanted to make that part short, because I know you guys have a lot of questions.
Who wants to go first?
Sure. You're closest.
I'm just curious, so all of these behaviors that sort of are an outcome of all this ADHD, having ADHD, or can you work with children, or is it possible to re-guide their brain so that they kind of can adjust themselves to certain behaviors, like we were talking about the oppositional behavior, other than just the medication? Because we have the medication in place, but I'm still seeing all of these other symptoms of ADHD, especially when they come off the medication later in the day.
Sure.
So what do you suggest? Like, okay, so for me, it's like blank slate. My kids are on medication. I need to find them other support. So what do you suggest doing?
Well, it's the behavioral interventions, and you can't just give the medication.
Right. So where do I go as like the mom? I'm trying to figure this out. What do I do first?
ADHD coaching, get the kids into therapy. I mean, we've kind of talked a lot of kinds of interventions. The thing is with the medications, they're so effective. They really are. But they have their downsides, of course. We can talk about side effects and so on. But the effect size, that is the amount of response that you get with stimulants, is huge. And that's why they're still around. That's why they're used. That's why we still use them. But with the biofeedback, it just hasn't shown to have that same kind of effect size. It just doesn't seem to be that effective.
I was just going to jump in. I've had a lot of clients do neurofeedback, and they see results, like short-term results, but it's not long-term. So, like, I've had a client who said, like, my kid went on summer break and played video games and it got erased. I don't know if it's that simple, but I think it's, the medicine is effective, and then if there's no skills or strategies being taught as well, you're not going to have the great long-term effects. Yeah. So you might see some results, but it may not last.
I have 2 questions.
Sure.
So it took me a long time to even consider meds. And my psychologist talked me into seeing my pediatrician to get medication prescribed. And a friend of mine was also seeing a psychiatrist who ended up working with her on the same thing. Both her psychiatrist and my pediatrician said, well, normally we start on high doses and then we back down as much as possible.
No, I did that.
Okay, so should I change pediatricians? Because I like the lowest possible dose.
Not to jump into your relationship, but yes.
Yeah. Because when he said that, I was like, yeah, I don't want to do that.
No.
We'll start
I mean, there's
Start
a,
low and see what happens.
we always, yeah, exactly. We always start low and go slow with kids.
Okay, and then my second question is he told me originally he said he wanted to do Ritalin is what
Mhm.
he sees the best experience at. And my psychologist had said that he would recommend Adderall. So we are using 5 milligrams of Adderall.
Right.
But like everything that she was saying, Adderall is no good. She recommended.
No, I didn't say that.
Oh no, I don't mean no
It's for
good.
my, for if you have addiction in your brain.
And I know that she does.
Well, I think the low dose of Vyvanse, but I'm not him.
So
And
what I'm wondering what your
I,
opinion is on the Vyvanse.
all my
versus
experience, they all work pretty much the same with individual differences. Some respond better to some meds than others. But also that question about addiction, I think, comes up with a lot of parents.
Yeah.
I think it's important to address. And the studies show that kids that are in full treatment, we're not just the medication, but with a full program, have lower rates of drug abuse later. Because what they do is they find that sense of satisfaction, that dopamine fix from doing well in the world, having great relationships. But if you're not getting that, you're having friends that are running off, getting into trouble, getting high particularly, they learn very quickly to short circuit that reward system with drugs.
Okay, so like you gave a really nice action plan, and what would your action plan be?
An action plan with what specifically? I'm not.
With like what program to put them on, like medication, behavioral therapy, sensory. I mean, I don't know.
I think
what are
it
the things you would recommend?
Well, I think it really depends on the kid, and that's why it's important to do a full evaluation. I think that oftentimes there are these garden variety ADHD kids that are so simple. I could just diagnose it and give them the
Not
right
the kid.
medication in 15 minutes, and then just try to make up things to talk about. But most kids are much more complicated than that. We talked about having and how there are so many other things that look like ADHD that might be contributing to ADHD, for example, anxiety, PTSD, disorders, which are also very common in kids that can look like ADHD.
That was my question, actually.
can I say something concrete? I want to give you one tool per year. There are a lot of people talking, and I agree with the idea that going through our school system with ADHD, you end up with PTSD, right? And I know it's alphabet soup, but here, let me do it with Jamie. You can do this with your children to calm them down. This is from EMDR, Rapid Eye Movement Desensitization and Reprocessing, that we use for PTSD. And you can just do this. I'm teaching you. Okay, follow my fingers. And just take a breath and just follow my fingers. You are safe now. You are home and you are safe and you are loved, Jamie. You are safe and you are loved. I love you. I love you very much. And you are safe. You're on a good path and I'm here for you. You are safe and you are loved. You do that for a couple of minutes. It's beautiful. Also the gaze, the research on the gaze, where you just look at your child and the head's in the lap and you gaze up, wordless, very powerful. Who was talking about where nothing works? You can do the gaze, where you just look. And they kind of like it, a little weird at first, but you do that gaze, it goes deep into the brain. You know that research?
Well, we're talking about attachment research,
Yes.
basically. And little kids, they learn to self-regulate by incorporating this regulation of the other.
Yes.
And so that's what a parent and an infant do when they're gazing into each other's eyes. When the baby is fussy, is they're co-regulating. As the parent becomes that containing, soothing object. And so that's basically what you're doing when you're trying to down-regulate a child with the eye gaze or with the oppositional defiant child going down and just being persistent.
Really good.
That was my question when you were talking about the multiple diagnoses.
Mhm.
How do you balance that because of the overlap of everything, and it's not just medication, it's the therapies and stuff
Right.
too, I don't want to give too much history, but my daughter started as a diagnosis of bipolar
Mm-hmm.
because she had the mood swings and everything
Right.
like that. And then after we medicated her and we can get some of it in focus and calmed, we eventually saw more autism and
Right.
ADHD, and the anxiety and stuff
Right.
started like appearing versus before it was just explosive both directions.
Right.
because it was sensory also. She had lots of sensory stuff. So how do you balance all of that with medications and therapies, because there's so many
Well, that's the-
diagnoses that, like, especially like bipolar versus ADHD or autism, they're two different worlds in medical standards and insurance. You know, it's like one go to the county and the other one, here's a whole list of therapies you have a choice of, you know. And as a parent, it's like we're not educated in this field and we're mumbling through to try to balance that. You assume that your child's bipolar and you go through that whole diagnosis of dealing with that, and then come to find out it's something else, and you have to backtrack and then deal with that another issue. And I know it's individualized to this child, because one could have sensory needs and the other one doesn't, and I have actually both. I have one that's a seeker and one that's an avoider, and that's autism and not ADHD. But how do you balance what to choose of therapies and what to choose of medications and what to trial and error things without spending your entire savings and time and energy and your brains and your whatever, because that has been my world. I've gotten to the point now, my daughter's 18 and I have not much left for my second child.
I just want to bring up
Just
that.
completing her, I face exactly the same thing, and besides the guilty to being wasting 10 years of my son's life without the correct treatment. He was treated like a straight ADHD, and only last year he was diagnosed as high functioning autism. And like, wow, I waste 10 years watching my son going down and down and down, and so
making huge amount of effort.
Exactly. We try
Not a
everything,
lot
but
of-
it was not enough because the diagnostic was not complete.
And there's so much
hard to-
overlap, though,
Yeah.
too. Half
Exactly.
of kids that are on the spectrum have ADHD at least.
Yeah.
And this
then
bipolar
once you have-
disorder was way overdiagnosed 15, 20 years ago.
Right.
This guy, Joseph Biederman,
Yeah,
and all these kids that had these tantrums and flare-ups and mood swings were all diagnosed with ADHD, and they all ended up on antipsychotics. But anyway, kind of back to your question,
See how good he is? Great.
But it takes a very careful very careful interview and diagnosis, getting a good history. That's why it takes an hour and a half just on an intake to really try to peel these things
Well,
apart.
a lot of that intake and information comes from the parent surveys and the 1 to 5 surveys that were given of, are they, when they respond, do they give you a mild reaction or big reaction? When they do this, do they, and yeah, sometimes they do, sometimes they don't. And I find that I just kind of just throw a number out there, and I kind of like, okay, this is worse than that. As long as my numbers are opposite, then fine. But it's like, it's hard to, when we're not educated in the technical things, to be able to assist in the diagnosis kind of thing in situations.
Well, that's why I don't really depend on rating scales very much. Because I think that, does my kid smile how often? But how does that smile feel? And it's a response to what? Is it like kind of a little howdy-doody smile? Like, do you feel a warmth in that smile?
Yeah.
And what is the kid smiling at? Gives you so much more information about the relatedness, about the relationship. I mean, like putting a number on it just doesn't really give you the information. Yeah.
We're going to have to sneak out, but
Yeah,
thank
we
you.
can continue, but we're
so
going to
much.
say thank you to Dr. Maxwell and
Thank
Jane.
you.
Thank you
Thank
so
you.
much for
Thank
being
you.
here.
Thank you.
Thanks
It's
so
wonderful.
much.
Thank you.
We'll follow up.
You're
Okay,
on your
I'll
route
send
to
you-
being Zen masters.
Thank you so much.
Thank you so much.
Jamie.
Yeah.
Question for her.
Oh, yes.
Part of my ignorance, and I haven't done any research compared to these ladies, so again, I'm sorry if this is a very basic question, but is there anything in the pregnancy or environmental or about the mother or about the household or about her being employed or not being employed or any other factors that are
Right.
reversible that maybe didn't have to exist
Right.
that led to this? Or is it all purely genetic and there's no environmental?
But my take on that is that maybe it has something to do with it, but not that much, surprisingly. But you think about a mother who's smoking crack right up to the delivery of a baby. What does that tell you about the mother's mental health? That she's probably very, very ADHD. So what much stronger factor is the mother's genetic ADHD or bipolar disorder, whatever she's bringing to the table.
Genes are much more important than anything environmental.
Because they've been doing that, looking at studies. What is the result of cocaine on the fetus? And there was a time when I was doing my residency where they thought, oh my God, the coke epidemic, we're creating an army of psychopathic kids, and look out. But it shows that there's not actually that big of an effect, and actually maternal smoking is a higher risk factor for ADHD than
Wow.
cocaine exposure.
Wow. Wow.
So this coke baby was really pretty much of a myth.
What about kids growing up with screens?
Uh-huh.
I hear from rumblings from teachers of littles, they're just bouncing off the walls. But is that just because we have a rise in ADHD, or is it because, toddlers, preschoolers are growing up with phones in their hand at Target so the mother can get through Target or the grocery store, or
Yeah.
whatever it is, right?
Right.
In every scenario, right? It's easy to hand a kid a screen. Is that truly having an effect on the brain and the attention span?
I would think so. I mean, it's sort of a chicken and the egg kind of
Right.
thing.
Yeah.
Because parents would always talk about, how can my kid have ADHD when he can sit playing Nintendo for hours all day?
Right.
Totally
And-
different part of the brain.
Yeah.
and the thing is that we're talking about, when we talk about executive functioning, we're talking about dopamine, that the world out there really isn't that interesting to people with ADHD. They're just kind of like floating through it.
Uh-huh.
And people talk about kind of a spaciness, especially as they're older. I feel like I was in a fog dock until I took my medication, and suddenly seemed kind of come into sharper focus and meaning. So you put these kids in front of the screen, and they're just getting these dopamine hits like that.
It's
So
an
it's
addiction.
just bam, 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 bam. And on the flip side, they're not kind of learning how to just be quiet, how to be with themselves. And it would, yeah.
I've heard, I am ADHD, but I've also heard like the TV screens. It's
Uh-huh.
like that, and I'm not sure if it's autism or ADHD, but where they have like 20, like you go into the stores and they have all the TV screens up on the wall, and they're all on full volume, and they're all going different channels, and you don't know which one to prioritize and how to distinguish between the two
Right.
and how to focus. So then you have to just numb all of them out
Right.
to be able to function and not overload.
And there's a good picture, there's a good metaphor for that. There was William James, famous psychologist back, and he's talking about consciousness and how do we sort of pay attention to one thing? Because otherwise reality is this blooming confusion, I think, as he put it, okay? But what the frontal cortex is doing, 90% of it is inhibitory. Which is why when you give an upper, you see a kid calm down and better able to focus. So what your frontal cortex is allowing you to do is to screen out all those other TVs so you can pay attention to that TV.
Jamie?
I actually have a question.
Sure.
I hope it will be helpful to some of you, but one of the most difficult comorbidities I've seen with children is anxiety. You had mentioned
Yes.
anxiety. And for twofold, sometimes I feel like the anxiety is causing you to not pay attention. You're over-focused or whatnot. And then also when they're on certain medications, it feels like the medication is causing them to over-focus on their anxiety almost. So how do we, as a team member
Okay.
or parents, kind of weed through that? And do you then do you do anti-anxiety meds? And so I know everyone's different.
Well,
but-
what you do is you prioritize. Somebody brought up, you try to, out of this sort of mess of stuff that's going on, you have to prioritize. In that specific question, what comes first, the anxiety or the ADHD, they go together oftentimes. If you have one, you have a higher chance of having the other. So you pick. Is the kid like so socially phobic can't go into a classroom? Then the ADHD is a little bit irrelevant.
Right.
But also I've had a lot of kids too, and a lot of adults specifically. They come in saying, I'm so anxious. And when you pick it apart, you realize that they're anxious, they never feel in control of anything. And everything's kind of slipping away, they're forgetting things, they're losing things. And if the sort of the base emotion of anxiety is that sense of not being in control. It's being powerless over what's going on around you. So oftentimes you give these kinds of patients their ADHD medication, the anxiety goes away.
Thank you.
Or like you learn the skills like with you do, is giving them a choice. Even if it's two choices they don't like, it just gives them that control and option of choosing it versus somebody choosing it for them, or they don't, have that ability to. I mean, I've done lots of two bad choices. They don't want to do either one of them, but then it gives them the option of having that control.
Let's do two more questions. Is that okay?
Sure.
Okay. All right.
You talked about comorbidity.
Mhm.
What is the top 5 comorbid disorders that go along with ADHD?
What is comorbidity?
Well, comorbidity, I know, it's things that go along with. Morbid is this awful word, like we were saying, for disease, disorder, something that's not working right. So what goes along with ADHD, and what other kinds of conditions does it seem to lend itself to? And there's a lot of them. I mean, like PTSD, for example, there's a lot of correlation. Because these are kids, if you have a chaotic household, and if you're running around climbing off the curtains, and you have a dysregulated parent, that kid's going to have a high chance of getting hit.
Do you think that that's more behavioral or more like chemical?
Which is?
Like if you're watching behaviors as a child,
Uh-huh.
right? And this is how an adult copes. This is how an adult does things. So you grow up to be an adult that does those same things.
Right.
And you're diagnosed with ADHD, like nurture versus nature.
Mhm.
Like you are born chemically different. Like, what is there? Different types of ADHD. You know what I mean? Can you?
Well, there are a lot of different types of ADHD, I think. I mean, ADHD isn't the thing. I mean, otherwise we'd have an ADHD one gene, this one thing that we could just go in there and do a genetic testing for.
Got it.
But we can't, because I think it's multifactorial. There's a lot of things to go into it with this final common pathway of not being able to focus, organize, self-regulate with impulsivity.
Right.
And so if you have a kid in a chaotic household like that, whatever kinds of coping the brain is going to be able to use to learn to self-regulate, focus, organize itself, is going to be undermined. And also that kid also is going to be, in danger for, developing PTSD, because we were just talking about in a chaotic household. Other comorbidities is the oppositional defiant one, and that's probably one of the biggest. I mean, something like half the kids with ADHD, particularly untreated, is a really high percentage of kids with ADHD start to develop oppositional defiant disorders.
I also see a lot of auditory processing issues. Auditory processing issues go along with, I get sent a lot of comorbidity of ADHD and auditory processing or
Right.
dyslexia. More on the academic part, but still, I see those two go hand in hand.
And I agree with that, because somehow there are kinds of dysfunction in executive functioning.
Mhm.
And if
And
you
the
tease it
processing.
apart,
Mhm.
yeah, you're going to find a lot of processing problems.
Absolutely.
So I feel like we could spend all day.
Yeah, really.
We could spend an entire weekend and cover, just go from topic to topic to topic. So we did not do evaluations. Of course, I'm thinking of that right now. Like we normally do for a workshop, we have you fill out an evaluation because we want feedback to know if this was beneficial and what parts were beneficial and what wasn't or what have you. So I don't have that, but I would love to hear from you. I'll maybe probably send an email to everybody who attended and just give me your feedback and where to go next, because I think we could certainly expand on this, or we could do a kitchen chat and, talk about something specific. We can do another workshop next year. We're planning and gearing up and budgeting for 2020, so we value your feedback and what you need and what you need to hear from, and maybe it's just like a 3-hour Q&A with Dr. Braslow, So when you, sorry to volunteer you. But all the handouts that we got, I will scan and send out. There were names that were mentioned today by the different professionals. I will get the full name and contact information and what their area is. Like Dr. Maxwell mentioned Holly Blitz, who sounds like it's a behaviorist. I don't know. Anyway, so we'll get that to you, not tomorrow. Give me some time. We'll get this to you. But thank you so much for being here today. Thank you. Thank you, Dr. Maxwell. Thank you, Jamie.
Thank you.